Imagine the human skull for a second. We usually picture it as this ultimate biological fortress.
Oh, absolutely. I mean, it's evolutionary armor.
Right. It's this incredibly hard, perfectly evolved dome, and it's literally designed to protect the most vital, delicate organ we have from the outside world.
Yeah, it keeps the rocks out, it absorbs impacts. It really is a masterclass in structural engineering.
It is. But today, we're actually looking at what happens when that impenetrable fortress suddenly, well, when it turns into a trap.
Which is a terrifying pivot.
Truly. We're doing a deep dive today into the hidden physics of the skull. Specifically, we're focusing on increased intracranial pressure, or ICP.
Right.
And the mission for this deep dive is to sort of map out how clinicians actually detect when the pressure inside that bone box is rising.
Yeah, and crucially, we really need to unlearn one of the biggest, most deeply ingrained misconceptions that's taught in medical education.
Oh, man, yeah. The warning signs.
Exactly. How to spot the warning signs of a brain in crisis. Because what you learn in the textbooks isn't always, well, it's not exactly how it plays out at the bedside.
Right, right. And just to set the stakes here, because they are absolute life and death, if you are a healthy adult, say just lying flat on your back right now, your normal pressure inside your skull is roughly what, like 7 to 15 millimeters of mercury?
Yeah, 7 to 15, which is fundamentally a really low pressure system, especially compared to systemic blood pressure.
Right, 120 over 80 versus, 10.
Exactly. But if that ICP number creeps up, and crucially, if it stays sustained over 20 or especially 25 millimeters of mercury, the data shows this sharp, just terrifying rise in mortality.
The biological fortress basically becomes a pressure cooker.
That's exactly it.
So let's unpack how that pressure actually builds. Because before we can talk about spotting those warning signs, you kind of have to understand the physical rules of the skull itself.
Yeah, you have to go all the way back to the late 1700s and early 1800s for this.
Right. Two Edinburgh physicians, Alexander Monro and George Kelly.
Monroe and Kelly, yeah. They established this foundational rule that still completely governs neurocritical care today. And they figured this out entirely from cadaver anatomy and animal experiments.
Decades before an X-ray or a CT scan even existed.
I mean, it's wild.
Yeah.
But they established what we call the Monroe-Kelly doctrine.
Which is like the starting point for understanding literally everything about intracranial pressure.
It really is.
So the doctrine basically states that the adult skull is a rigid, non-expanding box. And inside this box, you have exactly three things.
Right, just three.
You've got the brain tissue itself, which is taking up about 80% of the space. Then you have blood taking up about 10%. And finally, cerebrospinal fluid, or CSF, making up the last 10%.
And the key here is that brain tissue is essentially incompressible. You can't squish it.
Right.
And the adult skull absolutely cannot stretch. So the total volume inside that box is perfectly fixed.
So if you add anything new to it,
something else immediately has to leave.
The analogy that always comes to mind for me here is it's like a packed nightclub with a really strict fire code capacity.
Oh, we'll nick that.
Right. So the club is totally full. The brain tissue is the crowd on the dance floor, the blood is the bar staff, and the CSF is the wait staff.
Okay, yep.
Everyone's inside, and the bouncers at the door are absolutely rigid about this maximum capacity. But then a massive VIP shows up.
And in a clinical scenario, that VIP is a growing hematoma from a car crash or a brain tumor or maybe severe swelling from a stroke.
Exactly. So this VIP forces its way through the door, taking up space that just literally does not exist.
Right.
So to keep the fire marshal happy, or to keep the pressure from instantly exploding, the bouncers have to kick someone else out.
They do. They start shoving the CSF down into the spinal column, out of the skull entirely, and they squeeze out the venous blood.
The body is displacing its own native fluids just to make room for this mass.
Yes. And that biological bouncing mechanism, that creates what we call the compensation curve. And if you look at the mechanics of it, it is honestly one of the most deceptive and dangerous phenomena in all of critical care.
Because it hides the danger perfectly, doesn't it?
It completely hides it. For a while, those bouncers are doing a stellar job. The VIP is taking up space, but because the CSF and the venous blood are continuously leaving, the total volume inside the skull stays exactly the same.
So the pressure on the monitor stays totally flat.
Completely flat. This is the compensated phase, and it gives you this massive false sense of security.
Because that reserve is finite, obviously. You can only kick out so much fluid before there's just, well, none left to displace.
Exactly. Once that compensatory reserve is exhausted, once the club is full of the VIP and you literally cannot shove anyone else out, the curve doesn't just angle upward, it goes completely vertical.
Ooh. Oh, vertical.
Adding even 2 or 3 more milliliters of volume at that point causes an exponential dramatic spike in intracranial pressure.
And this explains a terrifying clinical reality. For anyone, working in an ICU, you could have a patient who looks perfectly stable for hours
Oh, yeah. Chatting with their family, vitals look completely fine.
because they're riding that long, flat part of the compensation curve, but then with no obvious external warning, they crash within a matter of minutes.
They hit that vertical wall. It's the physiological equivalent of walking off a cliff in the dark. The body hides the escalating danger until it physically cannot hide it anymore.
That is terrifying.
It really is. Though there is one important caveat to mention for you here. This rigid box rule, it applies to adults and older children. It does not operate the same way in infants.
Ah, right, because babies still have unfused cranial sutures and the open fontanelles, like the soft spots on the top of their heads.
Exactly. Their skulls can actually physically expand to accommodate rising pressure, so a bulging fontanelle becomes a really early, visible sign of trouble in a baby.
Wow.
Whereas an adult skull will just ruthlessly trap the pressure inside.
Okay, so the pressure spikes when the compensation runs out. But reading through these sources, diving into the physiology, the brain doesn't actually care about the pressure number itself, right?
No, it doesn't. It doesn't inherently care if the ICP is 20 or 25.
What it desperately cares about is whether it's getting enough fuel.
Yes. The math of perfusion takes over here. We measure this using cerebral perfusion pressure, or CPP. This is the actual physical pressure difference that drives oxygenated blood up into the skull and into the brain tissue.
And the equation for this is pretty straightforward, but the implications are wild. So CPP equals mean arterial pressure, your MAP, which is basically the average blood pressure in your body, minus the intracranial pressure, your ICP.
Right. MAP minus ICP equals CPP.
Which creates a really fascinating scenario. Like, imagine you're looking at a patient's chart. Actually, imagine two different patients. Both have a dangerously high ICP of 22.
Okay.
But patient A has an MAP of 1 to 10, and patient B has an MAP of 70. Mentally, you might think, oh, they're in equal danger because their brain pressure is identical.
Yeah, the bad number is the same.
Right, but one brain is fine, and the other is actively suffocating. Why is that?
It all comes down to the gradient. You have to think of the ICP as a physical resistance, like a heavy headwind that the blood has to fight against to get up into the skull.
Okay.
So if your systemic blood pressure, your MAP, is 110, it has plenty of driving force to overcome that headwind of 22. I mean, 110 minus 22 gives you a CPP of 88.
Which is great. That brain is getting a robust supply of blood.
Exactly. But if your MAP is only 70 and it's fighting that exact same headwind of 70 minus 22 leaves you with a CPP of only 48.
Oh, wow.
That brain does not have enough force to push the blood in. It is starving for oxygen.
It's basically this brutal battle of pressures, the blood pressure pushing in versus the skull pressure pushing out.
That's a great way to phrase it. And normally, a healthy brain handles these fluctuations beautifully through a mechanism called autoregulation.
The Lassen curve, right?
Yes, the Lassen curve maps this out. Across a massive range of normal systemic blood pressures, anywhere from an MAP of 50 all the way to 150, your brain's blood vessels will automatically constrict or dilate to keep the exact same amount of blood flowing in.
It's like a highly advanced smart thermostat for blood flow.
It really is. But when the brain gets severely injured, that thermostat completely shatters.
It just breaks.
It breaks. The injured brain totally loses the ability to autoregulate its vessels. It becomes entirely passively dependent on that math equation we just talked about.
So if the CPP falls below, what, around 60 millimeters of mercury?
Yeah, right around 60. That's when ischemia sets in. The brain tissue literally starts suffocating from a lack of oxygenated blood.
And that triggers this devastating vicious cycle, doesn't it? The brain tissue starves, so it gets inflamed and swells up.
Yes.
And then that physical swelling takes up more space in the rigid box, which drives the ICP even higher.
Which creates a stronger headwind, which drops your CPP even lower.
Causing more starvation, more swelling, and the loop just accelerates.
Exactly. And when that blood flow is violently threatened like that, the body mounts a desperate final defense mechanism. Which leads us to Harvey Cushing.
Harvey Cushing.
And his very famous Triad, which is central to understanding how we monitor these patients.
Harvey Cushing is such a towering figure. I mean, working in the early 1900s, he's generally considered the father of modern neurosurgery. Though, a quick warning to any nursing or medical students listening to this deep dive right now, do not confuse this with Cushing's disease or Cushing's syndrome.
Oh, yes. Very important distinction.
Right, because those involve excess cortisol from a pituitary tumor. Same brilliant guy, entirely different discovery.
Yeah, totally different. The discovery we're focusing on comes from a series of experiments. Cushing started in 1901. He was artificially raising the intracranial pressure in anesthetized dogs.
By inflating a small balloon inside their skulls, right?
Yes. And he meticulously watched what their cardiovascular systems did in response to the rising pressure.
And he noticed that as the pressure in the skull rose to match the blood pressure, basically choking off the brain's fuel supply, the body just panicked.
It went into full survival mode.
Right. It mounted this massive systemic reflex to spike the systemic blood pressure as high as physically possible.
Just a desperate attempt to force blood past that cranial obstruction to save the brainstem.
Wow. And this systemic response became known as the Cushing reflex. And the physical signs of it became Cushing's triad.
Exactly. The triad consists of 3 distinct clinical signs. First, you have a widened pulse pressure.
Meaning the systolic blood pressure shoots way up while the diastolic stays relatively low or normal.
Right. Second, you see bradycardia, which is an abnormally slow heart rate. And third, irregular respirations.
Okay, so this is where we hit the biggest misconception in neurocritical care that we found in the sources. If you look at generations of nursing and medical textbooks, Cushing's triad is taught as the classic warning sign to watch for.
Oh, it's drilled into your head.
Right. Rising ICP equals Cushing's triad. But the modern critical care literature demands that we absolutely, unequivocally should not be waiting for this triad to appear.
No, absolutely not. The textbook emphasis is essentially backward.
Really? Why is that?
It is entirely a question of timing. Cushing's triad is not an early alarm bell. It is a late preterminal sign of brainstem compression.
Preterminal,
Yeah.
meaning almost dead.
Yes. By the time that triad fully shows up at the bedside, the brain is already actively being crushed. If a clinician is sitting at the bedside waiting for Cushing's triad to appear before they intervene, they're waiting for a near-fatal event.
Wow.
In fact, modern studies show that the complete triad, like all 3 signs together, only appears in about a third of patients with critically high ICP anyway.
So it's not just dangerously late, it's actually rare to even see the whole textbook picture in real life.
Exactly.
And the physiology of the bradycardia itself, that slow heart rate, I find this so fascinating.
Yay.
Because it's one of the most counterintuitive mechanisms in medicine.
It is a massive biological paradox.
Right. Usually, if the body is in massive distress or bleeding out or suffocating, the heart rate skyrockets. Tachycardia. The heart beats out of your chest to save you. So why does it drop here?
Well, the brain is forcing that massive sudden spike in systemic blood pressure to overcome the pressure in the skull.
Yeah.
But the baroreceptors in your major arteries...
It's the sensors that monitor blood pressure.
Right. They detect this incredibly high, dangerous spike in pressure, and they trigger a vagal reflex. The vagus nerve essentially screams at the heart, systemic pressure is way too high, slow down, so the heart rate plummets.
Wow, so the brain is dying for blood, but the heart is being told to slow down by the body's own defense mechanism.
Exactly. It is one reflex completely fighting another reflex.
That is just wild. So if Cushing's triad is this late preterminal siren, we need to know what the real early warnings are. Like, what are the subtle whispers that tell us the pressure is rising while we still have time to actually do something?
The true early warnings require meticulous bedside observation. You are really looking for a drop of even just 2 points on the Glasgow Coma Scale, the GCS.
So this isn't just someone going totally unconscious.
No, not at all. This could be a patient who, an hour ago, was perfectly oriented and talking to you about their dog, and now they're suddenly using inappropriate words or just mumbling.
Or someone who was opening their eyes when you walked in the room, and now they only open their eyes if you physically inflict a pain stimulus.
Exactly. It could also be a new, unexplained restlessness or sudden agitation. A worsening, relentless headache is another one.
And there was a very specific kind of vomiting mentioned in the sources too, right?
Yes. Projectile vomiting without any preceding nausea whatsoever.
So they just suddenly vomit, no warning.
Right. That sudden vomiting is a direct sign of the brainstem getting irritated by physical pressure. Those subtle neurological shifts, those are the clinical indicators that you are reaching the very end of that flat compensation curve.
Okay, so let's follow the timeline where those subtle early signs are missed. The compensation curve goes vertical, the Cushing reflex kicks in, and the pressure remains completely uncontrolled.
It's the worst case scenario.
Yeah. The brain is now actively trying to escape the rigid box of the skull, which brings us to the mechanics of herniation.
Herniation is the anatomic endpoint of this entire terrifying process. You see, the skull only has a few rigid openings, mostly at the base where it connects to the spinal column.
Right.
When the pressure gets too high, the brain tissue has literally no choice but to squeeze through those openings. It's migrating from a high-pressure area inside the vault into a lower-pressure area.
And the tissue basically crushes itself against the internal architecture of the skull in the process.
It does.
I read about tonsillar herniation, which clinicians sometimes call cooning. What exactly is happening there?
So the cerebellar tonsils at the base of the brain are forced downward through the foramen magnum.
The large opening at the base of the skull where the spinal cord exits.
Exactly. And as the brain tissue crams through that hole, it severely crushes the medulla. The medulla is the part of the brainstem that controls your automatic breathing and your heart rate.
Oh, no.
Yeah. Once the medulla is crushed, the patient loses the ability to breathe. That is the fatal endpoint.
And then there's also uncal herniation, where the temporal lobe gets pushed sideways and downward.
Yes, and that produces the classic blown pupil, a fixed, widely dilated pupil on the same side as the brain swelling.
Because the tissue is actively compressing the cranial nerve that controls pupil constriction.
Right.
But digging into uncal herniation, the physics of it leads to a scenario that feels like a trick question, designed to just torture medical students. It's known as the Kernahan-Waltman notch phenomenon.
Oh, the Kernahan trap
Yeah.
is a brilliant and truly devious anatomical quirk.
The mechanics of this are so mind-bending, because normally the right side of your brain controls the left side of your body, and the left side of your brain controls the right side of your body.
That is the standard, ironclad neurologic rule.
Right. So if you have a massive bleed on the left side of your brain, you fully expect the weakness or paralysis to show up on the right side of your body.
Violently, yes.
But with this Kernahan notch phenomena, the mass on the left side of the brain pushes the entire brainstem so far over to the right side with so much violent force that it actually crushes the right side of the brainstem against the hard, rigid internal membrane of the skull.
The tentorium.
Yes. And because the right side of the brainstem gets crushed by the shifting structure, you actually get weakness on the left side of the body, the exact same side as the initial bleed.
We call this a false localizing sign, and I want you to connect this to the bigger picture at the bedside. Imagine you are a nurse or a doctor examining a patient who just fell and hit their head.
Okay.
You see weakness on their left arm and leg. Your immediate instinct, based on basic anatomy, is to deduce that the mass must be on the right side of the brain.
But the mass is actually on the left. The brain is just being squished sideways so severely that it's short-circuiting the opposite descending motor pathways.
Exactly. This emphasizes a critical takeaway for you here. Clinical motor exams can be incredibly deceptive when extreme pressure is shifting the brain.
Wow.
A blown pupil is a far more reliable clue to which side the lesion is on than a weak limb. The cranial nerve controlling the pupil gets compressed early and on the correct side. The motor pathways can get crushed against the opposite wall.
So the pupil doesn't lie, but the limb might.
Exactly.
Okay, so knowing how deceptive the physical exams can be and how lethal the pressure is, we have to look at how clinicians actually try to treat this, the bedside battle, basically.
It is a battle.
And what I found profoundly shocking in the sources is that fixing the pressure number on the monitor doesn't always translate into fixing the patient.
Yeah, it represents honestly the most sobering reality in neurocritical care. Look at two massive randomized clinical trials that were in our deep dive today. DeCra in 2011 and Rescue Extape in 2016.
Right. These trials investigated decompressive craniectomy. And decompressive craniectomy is exactly what it sounds like, right? Surgeons literally remove a large piece of the patient's skull to let the swelling brain expand outward, beyond the confines of the bone.
They literally take the lid off the rigid box. It physically eliminates the Monroe-Kelly doctrine because the box is no longer a closed system.
Right, because there's nowhere for the pressure to bounce back from.
Exactly. But the results of these trials were staggering. Taking off the skull successfully significantly lowered the ICP number. The pressure crisis was averted.
And in the Rescue Extape trial, it substantially reduced overall mortality too, right?
Yes. It kept them alive.
The surgery successfully kept people alive.
But, and this is the heartbreaking part, it left vastly more of those survivors in vegetative states or with severe life-altering disabilities compared to the control group that just received standard medical management.
Wow.
By letting the brain swell massively outward, the tissue survived, but the delicate neural connections were stretched and severely damaged.
So you cure the number on the screen, you save the biological life, but you potentially lose the functional person.
It highlights a foundational tension in this field. Just because we have the mechanical ability to control the physiology doesn't mean we are preserving the human being's functional capacity or their quality of life.
That is so heavy. And it isn't just the extreme surgical interventions that are heavily debated, right?
No, not at all.
Even the basic medical management of blood pressure has these fierce rivalries. The sources brought up this epic clash between two management philosophies in the 1990s. The Lund concept versus Rosner's approach.
Oh, yes. And they made perfectly logical physiological arguments that demanded exact opposite actions at the bedside.
Okay, so let's break that down. Think back to the cerebral perfusion pressure math we did earlier.
Right.
Rosner argued that to save an injured swelling brain, you need to crank up the systemic blood pressure. Use vasopressor drugs to force the MAP high, deliberately keeping the CPP robust so the brain never starves for oxygen.
The logic makes total sense. The brain needs fuel, so push the fuel in harder to overcome the resistance.
Right, but then the Lund concept, which was developed in Sweden, argued the exact opposite based on the mechanics of hydrostatic pressure.
Yes, the Lund group pointed out that an injured brain has a damaged, leaky blood-brain barrier.
So if you aggressively raise the systemic blood pressure,
You are just increasing the hydrostatic pressure against those leaky vessels. You end up actively forcing more fluid out of the blood and into the brain tissue, making the cerebral edema significantly worse.
so they're pushing fluid into the skull.
Exactly. So the Lund group argued for carefully lowering the blood pressure to reduce that swelling.
It's wild. Two entirely logical physiological theories dictating totally opposite treatments. One prioritizes feeding the brain, the other prioritizes stopping the swelling.
And decades later, there is still no universal winner. Modern guidelines generally aim for a cautious middle ground, targeting a moderate CPP.
And you see this same intense debate with osmotic therapy, right? Like the IV medications used to pull water directly out of the swollen brain cells.
Yes, the great mannitol versus hypertonic saline debate.
Right. So mannitol acts as a massive osmotic diuretic. It pulls fluid out of the brain, but then it forces the kidneys to excrete it, making the patient pee out massive volumes of fluid.
But the risk there is that you pull out so much fluid that their overall blood pressure drops too low.
Which drops the perfusion pressure we just talked about.
Exactly. Now, on the other side, you have hypertonic saline, which is essentially highly concentrated salt water.
Right.
It pulls fluid out of the brain tissue and into the vascular space without causing that massive diuresis. It supports the blood pressure better.
But it's not perfect either.
No, it requires a central IV line placed in a major vein, and it risks causing severe, dangerous spikes in systemic sodium levels. There are no perfect silver bullets here, just constant precarious trade-offs.
Which really brings the entire concept back down to the reality of what critical care nurses do every single day at the bedside.
Absolutely.
The daily interventions sound almost mundane, but they are physically load-bearing for the patient's survival.
They are the absolute unsung heroes of ICK management. I mean, something as simple as keeping the head of the bed elevated to exactly 30 degrees.
Right, just using gravity to help drain the venous blood down and out of the head, opening up space in the nightclub, basically.
Exactly. Or keeping the patient's neck in perfect neutral alignment.
Because if the neck is twisted or bent, it literally pinches off the jugular veins, right?
Yes, which traps venous blood in the skull and directly raises the pressure.
Wow.
Or treating fevers aggressively because a hot, feverish brain has a higher metabolic demand. It demands more oxygen, which demands more blood flow, which raises the volume and the pressure.
Even avoiding excessive suctioning of a breathing tube is a big one.
Yes, because the physical act of coughing creates a massive spike in intrathoracic pressure, which backs up right into the brain. It is a game of millimeter by millimeter management.
It really is. So, to bring us back to the surface after this deep dive, the skull is a rigid box. It's this brilliant evolutionary fortress that becomes a lethal trap when things expand inside of it.
You have a compensation curve that perfectly hides the danger until the absolute last second.
Right, at which point the pressure goes vertical.
And when it goes vertical, Cushing's Triad, the widened pulse pressure, the plummeting heart rate, the irregular breathing, is not your early alarm system.
It is a late-stage manifestation of failure.
Exactly. The real lifesavers are catching a falling GCS, noticing a patient who stops making sense, observing a subtle pupillary change, or paying attention to sudden vomiting way before the brainstem starts getting crushed.
Which leaves me with one final thought for you to mull over. We spent this whole time deconstructing Cushing's Triad, right?
Yeah.
It is one of the most famous textbook classic medical signs in history.
Yes, it is.
But if it turns out to actually just be a late-stage signal of impending systemic failure, how many other classic textbook warning signs in medicine are we sitting around waiting for, when we should be looking for the subtler whispers of the body instead?
It's a great point. If we only look for the dramatic alarms, we miss the window to actually help.
Something to think about the next time you look at a patient's chart.